Hi, everyone. It's 12 o'clock, so we're going to get started. Welcome. So excited to see you all and be together again on our third session for our Maine HPV Project ECHO. I can't believe it's the third one already, right? Time is just this fluid motion, isn't it? It just goes so fast. So I'm going to just ask people to go around. I'll call on you real quick and we'll do some introductions, and then Danielle will lead us into some housekeeping pieces, and then we'll roll into our excuse me, our agenda and echo. Excuse me. We're going to start with people on the line. Do we have anyone on the phone to introduce themselves?
Yes, this is Angela Briggs. I am a nurse at Winthrop Pediatrics for Maine General.
Hi, Angela. Welcome.
Hi.
Hi, I'm Denise Harriman, Certified Medical Assistant at Stockton Springs Health Center and Vaccine Coordinator.
Hi, Denise. Welcome.
Thank you.
Hi, I'm Danielle Turner. I'm the Practice Administrator for Kennebec and Winthrop Pediatrics, and I have Denise Breer with me as well.
Hi. Hello to both of you. Thank you for joining today.
Hi, this is Denise Cronholm at Family Medicine. I'm the Practice Coordinator and an MA and the Impact Coordinator.
Hi, Denise. Nice to see you today.
Hi, this is Teresa Marithu. Can you hear me?
We can.
Oh, good. I'm the practice manager for primary care and the interim practice manager for the 4 outlying health centers at Waldo County General Hospital. And today I have with me Dr. Lee Pursuto.
Great. Thank you both for joining. Okay. I thought I just saw Elizabeth there somewhere too, briefly. I did too. Okay, we can come back. Anyone else any other those folks that have not introduced themselves thus far? Okay, how about our faculty?
I can go first. This is Anna Hassan with the American Cancer Society, calling in from New Orleans. Hi, everybody.
Hi, Anna. Thank you for joining today. Teresa, are you able to hear us?
Yes, I can hear you.
Thank you. Teresa Knowles, can you hear us as well? She's asking.
Can you hear me now?
Yeah, now we can hear you. Yep.
Sorry about that. It's Teresa Knowles. I'm the Chief Quality Officer here at PCHP in Bangor.
Great. Thank you for joining. And I see Colleen, you've joined us. We're just doing introductions. I don't know if you can hear us yet.
Yep. Can you hear me?
We can. Would you like to say hello? Hi.
Hi, this is Colleen. I'm calling from Community Clinical Services, working with the pediatric office here in Lewiston.
Great. Thank you for joining us. And then we also have, I think, Elizabeth?
Yes, that's me. Hello, everyone.
Hi, Elizabeth. Thank you for joining today. Excellent. I think we have, is there anyone, I do see someone on the line. Would they like to say hello?
Someone calling from a 330 number.
That was Colleen.
Okay, great.
Thank you.
All right, perfect. This is terrific. Okay. At this point, I'm going to turn this over to Danielle to take us through a few housekeeping pieces, and then we'll continue moving forward.
Thank you. So just a friendly reminder, we're actually recording the didactic today as well as the full session. We have some folks from our case presentation practice that aren't able to attend. So we will record the whole session today so that they're able to watch it at a later date. This is lunchtime for many of us, so please feel free to mute yourself when you're not speaking to reduce that background noise. And then when you unmute, just say your name before you start speaking so we know who you are. If you're on the phone, *6 will mute and unmute you. Terrific. All right, everyone. At this point, what I'd like to do is I'd like to introduce Maine General Pediatrics, Kennebec and Winthrop Pediatrics, Kennebec, to Danielle Turner and Denise Breer are going to give us just a quick follow-up. We decided it, really to kind of give that follow-up after they presented, to kind of talk just briefly about some of the things that they may have done or what their thoughts are, to kind of loop back with everyone. So I'm going to turn this over to Danielle and Denise, please.
So I think we definitely have put a lot of work into our Gardasil vaccines and rates recently. We have felt it's still too early to tell how much the workload has made a difference, mostly because we've spent some of the time reaching out to patients and trying to get them scheduled for physicals and nurse visits to get their Gardasil vaccine done.
Perfect.
But once it's all hardwired for staff, that we'll be able to monitor the adherence and benefit of it all together. And then as far as recommendations that we have tried recently, I don't think there was anything new. Denise, would you say?
I wouldn't say there's anything new, but one of the things that Dean and I talked about that I found in doing the chart audits is that a couple of the really strong providers from both practices were developing a plan when they saw a patient in the practice and they administered the vaccine, that they at that point recommended, and Danny actually helped to promote this in the practice, to have them come back for a nurse visit at the right interval. So I could see that when I did the chart audits, that was actually part of the note, and that subsequent visit was already scheduled. So that's been, I think we'll see those rates climb because of that practice. And those two strong providers, I think, in meeting with the provider group, will help be able to spread that workflow.
Mm-hmm.
That's true. That's awesome.
We also have been trying to train additional staff to help with the workload due to some of our changes in management structure within the practices. So that has been another ongoing process that we've been working on.
Terrific.
And then we also are supposed to be getting a new electronic medical record system within the next 2 years. So we're hoping to include the immunization report capacity with the new system, and hopefully that will help with our rates as well.
Absolutely. And you'd be able to pull at provider level too, right? Is that your thought with that as well?
Correct.
Yep. Right.
Yeah,
That's
our current system, we are unable to do that with. So that should make a big difference.
Absolutely. And that's pretty standard, I think, too. Most practices don't have that ability that I'm aware of to pull provider level. Some do, depending on the scope of the system and how big it is, right? And the IT support. But that's great.
Yep.
Excellent. I'd love to hear about scheduling that second HPV dose. That is so, and not only that, but to see it documented in the note that happened and that conversation happened is terrific. And I'm sure that was really nice to see as you were doing that chat audit. So that's excellent. Great.
Yeah, and we've worked with our clinical staff to make sure that the medical assistants are kind of, making sure families are aware that it's important to get the 2 doses 6 months apart, or 3 doses depending on the age, and to have them in the right interval. So I think they're having that conversation as well as the providers.
Perfect. No, that's excellent. Great job. That's wonderful. Thank you so much for that update. And I think that's been really helpful to hear all the work that you're doing. So thank you so much.
Thank you.
right, everyone, we're going to dive into the didactic component today, and this is when I typically introduce the presenter, and so that's really easy for me today. I am so excited to be the presenter today for all of you, and really talking about, because I think this is foundational in this work, and I hope that you all agree, but really creating a pro-HPV immunization culture, really that exists, and we want to do that because we want to prevent HPV-associated cancers. Next slide. In the work that I have done, so in my background, as you all know, I'm a nurse practitioner by trade. I know we talked about that in the very beginning. And typically with the presenters, like with Anna and Teresa, I've given you a little bit of bio, but I think you all know or remember that from now. So I really embrace this piece because I feel like in doing this work, these are the 5 big components that I think of. So, and I'm going to take a little deeper dive into each of them with the understanding I know I only have 10 minutes, and I'm trying a little bit of something fun with technology today and a video for you all as well. So I want to make sure I have time for that. So these are the 5, I think, big key takeaways. So engaging all your staff and finding a clinical HPV champion and champions so that you all, right, all your staff become champions. Knowledge is power. I say this all the time. Educate, educate, educate. HPV education for all staff members is an evidence-based intervention, teaching your staff how to make these strong, presumptive, bundled recommendations for HPV vaccination, clear practice messaging and talking points so everyone feels empowered and confident in these conversations, and then clarifying the roles and responsibilities around the communication around immunizations in the practice with parents and patients. So everyone knows who's kind of doing what and who's having those conversations. Next slide, please. So this is Anna's fabulous slide that I am shamelessly, but I did ask, I have to say, to use this because it just shows how, as the faculty, we're trying to really kind of incorporate all this didactic to flow together. And so she had done a high-level overview on evidence-based interventions, and you can see where the piece I just talked about, professional education, that strong bundle recommendation, and leveraging clinic champion to change attitude and behaviors falls right into that, and that's what we're talking about today. Next slide, please. So engaging your staff. So one of the big things I think that's important is to always remind and take a little time, maybe at a staff meeting, you know, when you're maybe talking about the newsletter, maybe you're talking about some resources, you're talking about your data, and really sharing a couple of these quick videos to really remind people why we do this work. So we're going to give this a go, and we're going to show the first one is actually one that was just developed in July from the Maine CDC. It's a great little snippet that can be played on your TVs in your offices, and we're going to roll this one right now.
When I was 22, I tested positive for the HPV virus. My biggest fear was that it could impact my ability to have children.
HPV vaccination prevents cancer in thousands of men and women every year.
I'm so happy that today there's a vaccine that can prevent HPV-related cancers. My children are now fully protected and won't have to worry about these cancers later.
Talk with your doctor about vaccinating your children. Brought to you by the Maine Center for Disease Control and Prevention.
So there you go. So that's a quick snippet. Again, just a really nice piece, right, on that education. And then this is a bit of a story.
Really
so
what was going to happen was the most terrifying when I sat down with doctors and started talking about what it was and what we were going to do. Regardless of the outcome, I didn't think about that. I thought about the plan and what I had to do to get through it. My name is Frank Summers, and I was diagnosed with HPV-derived squamous cell carcinoma in my left tonsil when I was 45 years old. Well, having cancer impacted every part of my life really significantly. Of course, I was young and in great health and never really had a problem, and all of a sudden I'm dealing with cancer. And so emotionally, that was an incredible blow to feel like I wasn't a young, healthy man anymore. Physically, it was incredibly profound. I lost weight, lost strength, lost focus, ability to do things. It was a real struggle. If I had 30 seconds to send a message to everybody in the world about HPV, I think it would be Well, it would simply be awareness. It would be to say you need to realize that this is a problem out there, and it's a problem that we can't be shy about or uncomfortable with. It would be, it's a problem that everybody and anybody can have, and the consequences are huge. I've had a number of friends with children as a result of me who have decided to get educated about it, have become aware of the problem, and then have gone and vaccinated their children. To me, I can't think of any reason why you wouldn't do it at all. If you could vaccinate someone and potentially eliminate what I went through, it wouldn't be a question.
So incredibly impactful, I feel. I hope that you all maybe can nod, raise your hand if you liked it, felt that it was impactful, excellent, and I think wonderful. I love to see those hands. I think, and this was shared by Anna, and the links are in the slide deck to all of this. So as you look at this, you'll be able to go back and click on these and get to those direct links. And there's more stories like that that are similar to this. So again, these are just nice reminders that, again, we have this vaccine that prevents cancer. And like you said, why wouldn't we, right? This is our job, is to educate and promote this so that no one has to go through what he went through, right? We can prevent this. So finding clinical champions is another important piece. And when I say that, it's really plural. But really thinking about all of you here on the phone today, you are the clinical champions to me and to everyone who does this work. So looking at the leaders that you are to help make effective system changes. And I think it's a team-based approach. It really has to be in this work. So, whether and I think it's two ways when we say that, right? So we mean provider, RNMA, depending on who's linked to your provider, and your PSR team. So you have a team that's focused, right, on their patient panels and outreach and education and working together on that, huddling in the morning, pre-visit planning, all those things. And then you've also got the entire practice really on board together. Next slide. So again, I call it educating and empowering, right? Like we said before, knowledge is power. So HPV education, involving, again, that entire practice in that piece. So clinicians, RNs, MAs, front desk staff, basically any staff in your practice who has contact with patients should have this education. And I've done this and gone out to practices, and I think it's really important to show the front office staff too that they have an important role in this. We have the HPV, the National Roundtable Action Guide, that specifically calls them out as a specific role in this process. And so I think that's important to share them. And I think, knowing, again, I put together at the end of this slide deck some resources for you for the top, really where I go first. There's lots of others, but I would say these are the top 4 for resources to educate your staff. Obviously, with this HPV ECHO, that is part of our role, is to provide these resources to all of you. As you all remember, in the beginning of this, I had done an HPV training, You Are the Key to HPV Cancer Prevention. We do have that recording available. So if you want to have, again, another lunch and learn for some of you that just joined yourselves but want to share it with your practice, you can. And then we have the monthly newsletters, again, with practice and parent resources, learning opportunities, and sharing your data. Teaching all staff how to make a presumptive bundled recommendation for HPV vaccination and cancer prevention. So again, who kind of initiates that conversation in your practice? Is it the MAs that have that initial conversation? Is it the providers that have that conversation? And really thinking about, we have research that shows that it really matters how you present it. And if you present it in a way that you assume that parents, right, these presumptive statements that they're ready to vaccinate, are more effective than an open-ended discussion with parents. And the CDC recommends this bundled approach. And there's, again, been more research on this, actual behavioral research, that shows that if you recommend it the same way, the same day, and bundle it together, and do that the same way you recommend other adolescent vaccines, that you will have a bigger impact in getting your adolescents vaccinated. Next slide. This is one of Anna's slides, again, that rolls nicely into this, looking at, again, that strong provider recommendation. And truly, that strong provider recommendation from a child's healthcare provider is the most significant factor in a parent's decision to vaccinate their children. And again, all of us all of the people in the practice have a role in that. And again, that same language for the, well, again, if the medical assistants are doing it or the providers, now that your child's 11, they're due for 3 vaccines that are really important for all kids their age. Normalizing this, right? They will help protect against meningitis, HPV cancers, and pertussis, and we'll be giving these shots at the end of the visit today. So also putting the HPV cancer in the middle is actually an evidence-based piece in the fact that they have found that by putting that in the middle, that will also tends to increase uptake in getting the HPV vaccine. And recent studies show that a patient who receives this recommendation is 4 to 5 times more likely to receive the HPV than not. The other piece I just want to put in here is I think it's also important, and we've talked about this in the past, a couple echoes, in really starting that conversation around age 10 again, right? Because the first time that we're talking about this with the parent and the adolescent may be at that 11 visit. So we're asking them, you know, that could be up to 4, right, vaccines if they get the flu vaccine. And I think, again, they may be that hesitancy because they just don't know enough about it. So if we could be proactive and get that information to them at their, you know, 9 or 10-year-old visit, I think we can really see some impact with that. This is just one research study that I put in here for you all. The link is at the bottom. But again, just showing the research around this and the architecture truly of those discussions of provider and patient vaccine. This was at a health supervision visit. It was in pediatrics 2013. Very relevant and really looking at that parent-provider communication and determine the influence of a specific provider communication practices on a parent's resistance to vaccine recommendations. So basically they videotaped provider and parent discussions, and they looked at 111 of these, and it was with 16 different providers from 9 different practices, and 50% of those what they classified as vaccine hesitant parents. And what they found in this study, not surprising I'm sure to all of us, is that how the providers, again, and I want to say clinical staff, initiate and pursue the vaccine recommendation is associated with parental vaccine acceptance. Next slide. It's also important as we empower the staff in the practice to have clear practice vaccine messaging and talking points so everyone is on that same page. And this first bullet, I really can't highlight a lot, enough. And is really one piece that I want you to take away, I guess, from this presentation is the fact that we need to take the time to find out what is that primary reason for that parent's hesitancy. Did they read something, did they find something on the internet? Is it around safety? Is it around sexual activities, around fertility? What is that primary reason? We want to welcome and encourage questions. I think that that's really important because that's how we have that opportunity to educate. Providing talking points to all staff and really to build that confidence so that over time they won't need those talking points and they'll feel very confident about those conversations. Handouts to educate parents and patients. So they're coming in for any visit type. That's an opportunity, even if it's a sick visit and the provider feels that they're not well enough to get that vaccine, we know that this is an opportunity to educate and to make that appointment on the way out. So again, having those handouts to educate parents and patients. And remember, declination is not final, right? It's important to revisit and educate at every appointment type. Here's some resources. You have these already, but I put them in here just so you can see them. Again, these are specific talking points that fold into this presentation around talking to parents around the HPV vaccine. This is for staff. I think that is really a nice piece. And then the next one. For the clinical support staff, and this one is specific and directed to clinicians. It's a really nice piece. It's pretty new, and I really like it because it's a couple pages long, but it's written really well, and it basically has a nice piece where it says this is a good time, this is when you can get the vaccine, and this is when you can't. So it's a really nice piece, I think, for clinicians to have. And again, you have this already, but here's another link to it. But finally, in wrapping up, clarifying the roles and responsibilities around immunization communication with parents and patients. So again, I've mentioned this before, but who initiates that HPV vaccination discussion with parents? Is it the provider? Is it the MA? Is that process seamless? When in the process are you giving the VIS sheets? Or if they're declining, who's giving those additional education materials to the parent to take home and look at? And again, please call us if you have any questions, take a look at these, and we can talk about it the next time you come in. So again, always leaving that opportunity. And again, just
I can't stress this enough too, but really assessing that vaccination status at every visit type and that pre-visit planning process, it's always an opportunity to educate. And again, I think a lot of you are working on this as you're looking at those, as they come in. And if it's not that time to get it, then to make that well-child visit if they need it, or that vaccine-only appointment at checkout. So here's a quick resource piece that I put together. These, again, are the top 4 that I use, and I think that you'll find them very helpful, and again, there's lots more. If there's anything specific that you're looking for, that you feel like that you want to educate your staff, or research articles around fertility, all these pieces that you want to have in place to be able to hand to parents, please let me know, and I'm happy to get those to you. So really, truly, we want to empower every member of your team and your practice to become an HPV vaccination champion and truly save lives. And that is why we're all here today and doing this work together. So thank you so much. And I just want to give a quick minute to see if anybody has any questions. Excellent. All right. Feel free to put any questions in the chat box too. I always want to mention that. And I'm just going to turn this over to Danielle for a quick check-in here.
I think we're actually all set with attendance. If anyone is in the room and someone else's name is on the screen, if you can just put their name in the chat box, that would be wonderful. A lot of you have already done that though, so we appreciate it. Thank you.
Terrific. I do want to just take a minute, though, to introduce, we do have someone different here on our team. And Danielle and I, both of us now, Annie, who does our wonderful tech piece for us, but I'd also like to introduce and have Lise introduce herself and just say a quick hello.
Oh, certainly. Well, thank you, Jessica. Just happy to be here. This is a very exciting project. I'm a consultant here at Qualidyne and work on other ECHO projects. So just really happy to support this project today.
So Lisa's going to be our note taker today. We have vacations and things like that. So happy that she can join us and help us with that piece. Excellent. So I think at this point, what I'd like to do is introduce our case presenter, our practice today. And I just want to remind everyone of the ECHO process. So the case will be presented, and then I will ask for clarifying questions from the people on the phone first, and then the spokes, and then the faculty. And then we will go around and do recommendations in that same order with the people on the phone, the spokes, and then the faculty. So just a quick reminder, and if you can say your name real quick if you have a question, that's great too. I think we're all getting to know each other, but still nice to have that recognition of who you are. So at this point, I'm happy to introduce Teresa Merithu. She, again, had introduced herself as she's the practice manager, and she is basically going to be presenting for Lincolnville Regional Health Center today. And we're so happy to have you with us, and thank you so much for doing this. So I'm going to turn this over to you, Teresa.
Good morning, thank you. So I do have Dr. Lee Pursuto out of the Lincolnville Regional Health Center here with me today, who'll be presenting as well. Hello.
Oh, terrific. Thank you. Welcome.
So I know that we traditionally should be using the PDSA cycle as the presentation format. However, today what we would like to do is present our question in a kind of a scenario format, and then ask for feedback on growth opportunities for the particular issues that we're dealing with out of that location. So one of the things we are really struggling with right now is well-educated parents. So this includes parents in the medical field who are choosing not to vaccinate with the HPV vaccine. And it doesn't seem to matter how we frame it or how we present it. They have, unfortunately, in some cases, received data that they are miscuing on their perception of what that means. They're also looking at historical vaccination rates for the HPV vaccine and discounting some of the statistical data due to aging of that data and the time that's been administered to the patient versus how long the data is actually saying that we've been doing it. So they're definitely looking at that information a little bit differently. I'm going to let Dr. Pursuto jump on that as well.
Yeah, so we're having a lot of pretty well-educated parents, some in the medical field, who are just saying that the vaccine hasn't been around long enough, so they don't feel that it's safe. They're okay with other vaccinations, but just based on how they perceive it to be new, they don't want to vaccinate. So how are other people getting around that sort of conversation? What kind of tactics are other people trying? That's what we're kind of looking for and hoping to get some help with that. What specific resources are people directing these individuals to?
Great, thank you so much. So I think that's pretty straightforward. Sometimes we'll do a case, summary, but I think that is, you guys did a great job. I think that's very straightforward. So I think certainly that is a great, I think that's a great topic, a great challenge for us all to talk about and really kind of brainstorm around, because I'm sure that that is the case at every practice. So I'm going to, at this point, open it up to anyone on the line for any clarifying questions.
This is Elizabeth from Hometown Health Practice. What percentage of your patients are presenting as this? Is it greater than 5%? Or that is, does it reach significance?
It's definitely greater than 5%. I would say it's a pretty significant group of population for us.
Yeah.
It's a great question. All right, any other questions, clarifying questions from any of the other folks? I'd like to open it up to everyone on video as well. I think everything's pretty straightforward. Anything in the chat? No? Okay. I'd also like to now open it up to Anna and Teresa Knowles, our faculty, and see if either one of you have any clarifying questions.
Sure, I can start. Thank you for presenting. I had a few. One of my questions was around how the recommendation of the HPV vaccine is being given. I know a lot of folks know already about the presumptive approach that Teresa just presented on, but have you had a clinic-wide training around a bundled approach?
Yes, actually most of our team has sat in on the initial HPV vaccination talk, where we talked about not offering, like, do you want to, have you thought about, but rather this is just what is naturally in the immunization pathway. So
wonderful. And are providers recommending it at every visit, or are you finding that it's a specific type of visit where these issues are arising?
I'm recommending it at every visit. I don't see too many children, unfortunately, on a daily basis, but I'm trying to recommend that when it comes up.
Okay, and the policy is that whenever the kids come in, you ask every time, even if the parent had refused it the first time?
Yep, every time.
Okay.
Correct.
Wonderful, sorry. Yeah, those are my clarifying questions. Thank you.
Thank you.
I had a couple of questions as well. So when you talk a little bit about their perspective that the vaccine's not been around long enough and that they were looking at data, were they looking at the US data, or were they also looking at your other European countries' data?
I think they're looking at all data, but I can tell you that it has been actual members of our own team who have heard your data.
Interesting. Okay. Yeah. And then are we actually giving them any of the, so it sounds like the members of your team have received all of the data for as long as this vaccine's been out there. Are you also giving that to patients as well?
We'll give the patients any type of data they request. If we get somebody who's really questioning the VIS sheet that's given out or what the providers are presenting to the patient verbally, we can always give them hard copy papers to go home with. That's often our first step, is to have them have something to go home and digest and hopefully call back and want to schedule. We have tried just scheduling appointments for 2 weeks for them to come back for other vaccines, or just a random follow-up and having them have that information and then have something to be able to review back with them. But that, again, I think they get into that rabbit hole of Dr. Google with that information, and then we wind up sometimes a little further back than we intended.
Absolutely. And I actually
had one. Oh,
go ahead.
Sorry.
No, go ahead.
One other quick question.
Sure.
So when they are sort of challenging the data, are they concerned about it not being effective, or are they concerned about potential side effects?
A little bit of both. Yeah, I think a little bit of both concerned about the efficacy and then also about potential side effects because of the length of how long it's been studied.
Great. Any more questions, Teresa?
That's all I had.
And I think you actually answered a couple of one of mine, because I was actually going to ask what specific interventions had been tried, and you did touch on that a little bit. You mentioned, kind of giving hands out so they're leaving with something, and then again trying to schedule appointments for a couple weeks, maybe for them to kind of come back in and revisit that conversation. Is there anything else that you could share that you could think of that you may have tried already, as we think about recommendations?
I think those are the only things that we've tried. It was the hope that with this audience that we would be able to gather more potential things to do for these folks. Mm-hmm.
Absolutely. No, it's great to know what you've done a little bit in the past too, for all of us to think about that. And then who initiates, just again, looking at process, who initiates the conversation in the practice? Do the MAs initiate the conversation? Is there, when they room the patient, do they say or is it the provider that has the immunization conversation?
So both. All of our MAs do pre-visit planning, so they know what the patients are due for. They've all been trained to give that presumptive conversation, which is, this is what you're due for today, we'll be doing those. And then the provider reinforces, or if the patient declines at the time that the MA makes the recommendation, they can let the provider know which ones they're declining. So hopefully the provider can go in and have a little more sway with their decision.
Perfect. That's actually a perfect answer. So that's great. And I think that's great that you've had that training with all of them, and that they all do that presumptive, recommendation. So that's great. And then if they decline, is it the provider that gives the handout, or does it then go back to the MA to give the handouts as they leave? Again, just thinking process, how that works.
Usually the MAs have it because they're able to keep it in their area that they can hand it. I'm sure that if it was something the provider wanted, they would just let them know. We also use Epic, which allows us to drop a lot of the information into patient instructions. So we're not just sitting on a ton of paper, and it automatically prints for their after visit summary. So it becomes part of that bundled process of, here's the information about your visit, here's your next visit, here's additional information regarding whatever it is that you declined that day.
Oh, that's excellent. That's great. That's the first time I've heard of that, actually, providing that extra, if the vaccine's been declined, that the EHR will actually provide that added education. That's great. Okay, and I guess one last thing, is there any big concern above all? Is there, if you had to name the top one, what would you say that is, that you hear the most from these educated parents?
It's longevity, the longevity of the vaccine and how long that it's been used, and not having enough documentation over there not being side effects.
Okay, great. That's helpful. All right, so I think at this point, I think we'll roll into recommendations and thoughts to share, kind of, again, what you have been doing, thoughts you have for this team to address these concerns. And so we're going to go to anybody on the phone that is not on video to see if they have any recommendations for on this folks.
Hi, this is Elizabeth, and it's hard for me not to get emotional about this, because I've just, in the past 2 years, exactly 2 years ago, I was diagnosed with cancer. It was rare and deadly. It wasn't HPV, but the impact of the treatment and the experience of going through that journey was so life-changing for me that I think this is my opinion, I think we are doing a very poor job of describing the risk-benefit ratio to our patients when we are describing a treatment, an intervention that can prevent an incidence of cancer. And where my cancer was relatively painless. In fact, it was painless. I had no idea I had it. But this is a type of cancer that is located in highly sensitive, in highly sensitive areas of the body. These are the genitals, which have a very high rating of value in humanity, and in the mouth. And with the treatments, the radiation treatments to these structures are so painful and invasive that I cannot understand. I give the benefit of the doubt to the parent that they do not understand the true risk-benefit ratio involved in offering this vaccine. The side effects of the vaccine and the lack of experience with it are pale in comparison to what the impact of that disease will be if it sets in. And the probability is very high in the United States of this happening because of how often we are engaged in sexual activity, which I will remain not commenting on values in association with that, but just the fact that we are engaged in this activity with the frequency that we are in the United States tells me that this is a vaccine that has high value in the risk-benefit ratio. But I'm very emotional about this, and I'll desist from speaking.
Oh, thank you so much, Elizabeth, for sharing. I'm sorry to hear about that, but I'm so glad that you're doing well. And I totally agree. And I think that you have touched all of us with that impassioned and very well said. I thank you for sharing that. I think that I think really maybe that's the conversation, is how do we take a deeper dive, right? What are those talking points to really address the risk benefit? Again, you have that lived experience, and again, can't imagine, right, why someone would not vaccinate against that. So thank you so much for sharing that with us. I so appreciate it. I know we all do. Anyone else have some recommendations for Teresa and her team?
I think one other thing that's important with patients is their level of trust with either the clinical staff or their providers. And we've seen, if someone that they trust speaks to them and gives them more information about the vaccine, that they're more willing to get it.
Danny had a very poignant experience on the phone with a patient's mom the other day, and I'll let you, Danny, tell them about that, because I think that's really important.
She was upset with us for showing her child pictures of genital warts and some of the Gardasil resource information that we use. He's a 17-year-old boy, and the provider felt it was important to show him, what the vaccine would prevent against. So I ended up spending probably 20 minutes talking to mom and educating mom. And I've known her most of this child's life. So by the end of it, she actually made an appointment to come in and have him get the vaccine.
Well done. Yeah.
It's also important to tag along to what the presenters are talking about today, and it's about the educated parent.
Mm-hmm.
And this was a teacher.
Mm-hmm.
So she comes with education, she comes with knowledge, but she also comes with the idea that she wants, the proof is in the pudding. And Danny was able to relay those messages, and I thought it was, just like a beautiful opportunity and something that is going to probably help her staff model.
Mm-hmm.
I agree. That's amazing. And I think it is that trust that you're building, and then spending that extra time. Obviously she needed the gift a little bit of your time, and we know that sometimes is a challenge, but I think, obviously what you said was very impactful and helped change her mind. So that's a great example. Thank you. Any other folks have any other recommendations? So I'll call on people, because I think that also helps too. So I'll just kind of call out, I'll give people, I guess, a chance to, if they want to just make a recommendation. And if not, I'll just do like we usually do, just a quick call to see if you have anything. And you do, you can obviously certainly share that. And if not, you can, say no recommendations at this time. So anyone else would like to have any recommendations before I do that? All right, I'll start with Colleen. Do you have any recommendations or thoughts? Colleen, can you hear us? I don't think you're on mute. Is she on mute right now?
Probably, she might be a star 6.
Maybe a star 6? Yep, you were just unmuted, I think, Colleen. Oh, she goes. There you go.
Can you hear me now?
We can, yes. Any thoughts or recommendations?
I don't really have any additional recommendations. It sounds like I would just say, yeah, the trust thing and goes a long ways, and just being able to have that time to talk through the concerns that the parent may have, to really listen. But I don't have any additional recommendations. I'm sorry.
No, that's great. I agree. Just validating that component. Thank you. And then Denise Harriman, do you have anything to add?
I don't really have any other recommendations. I feel like everybody that is in this group, that the ECHO project, we're all facing the same problems, and our projects, it seems like every presenter is basically presenting the same issues. But one thing is the trust works out a lot. Everybody in our office that has children are fully vaccinated, and we use that as a standby and let people know that my daughter's 23, and as soon as she was able to have the vaccine, she had it. And I think that that makes a difference when you say that, you know, that my child had it, she's fully vaccinated. I wouldn't recommend anything I wouldn't give to my own child. So.
No, absolutely. I think that's a great point. Absolutely. Again, building that trust, because I know you give it to your own child. Thank you. That's a great recommendation to talk about that if that's appropriate, that fits that. And then Denise Cornhole, any thoughts or
recommendations at this time? I do have a comment.
Sure.
Not only the educated parents that we have an issue with, it's those parents who might think that they're educated on the subject. They do their own at-home research, and that's what they bring into us, stating reasons why they're not going to vaccinate their child. So, I mean, like Denise Harriman said, I think it's the same sort of situation that we're all dealing with in all practices.
Absolutely. Thank you so much. I agree. It's both, right? Educated and those who self-educate. Great point. Also, how about Angela from Winthrop Pediatrics? Do you have any thoughts or anything to add, Angela?
I think that just making sure the parents are aware that it's not just genital, cancers or HPV is a good key point too. Making sure that they know that the oral cancers can be caused by that as well. May open up their eyes just because it is a sensitive subject. And I agree, making sure that the educated parents know that, all of our providers do vaccinate their children 100%, and as well as our staff members. And it really is the only vaccine that can prevent some type of cancer. So that's great to just keep pushing along. Absolutely.
No, that's a good point about the oropharyngeal piece too, and that actually kind of gave me an idea at the end. I won't say it until at the end, but you're actually saying that kind of gave me a thought. So no, that's a great idea. And I think, again, if mentioning just like Denise had done too, but again, if there's providers and staff in there who've given it to their own kids, I agree, very impactful. So thank you. Okay, so anyone that I have not called on yet? Let's see. Sounds like Melissa's having tech problems. Melissa, if you have anything you can put in the chat, feel free to do that. If you disconnected. Okay, all right. So I think that's everyone. Is there anyone that I have not called on that would like to make any recommendations before we go to faculty? Great, thank you all. All right, Anna, you would start with clarifying questions, so maybe we'll start with Teresa Knowles. Do you have any recommendations you want to share?
The only thing I think that makes, well, so for me, what you mentioned about your staff having some concerns, and it sounds like it might be even providers in your practice having concerns, I think the key would be to work with them, because if they're not feeling comfortable, they're likely not going to be effective in convincing others to get vaccinated. So I think that you sort of need to start there. And I'm not sure how the data has been presented. I know it sounds like they've had some of the teaching that Jessica's done, which is excellent. I wonder if there are some resources from the CDC that sort of make it visually. So looking at sort of the efficacy of the vaccine since it's been out, not just in the US, but you know, I think it's been out for quite a few years. So it's pretty good evidence and been out there a while. And then also the actual visual data of side effects, you know, actually, you know, the numbers, how many people are going to have a serious side effect, what are the most likely side effects going to be. And so hitting people with just visual data so that they can look at that and being able to describe that, I think is best. And it may take a while, right? So it may not be just a one-time have the conversation, even with your providers and staff. It may be over a long period of time. I really liked the videos that Jessica showed, and I think maybe playing those for your staff and even your patients. They're short and they hit home. That may be helpful as well.
Great, thank you so much, Teresa. Anna?
Yeah, thanks for all the great conversation. I think it sounds like it's twofold. So around what you can control in-house, there's a bunch of different ways to educate folks. I know you said you had a presumptive approach, bundled approach training, but there has been a system in Texas who similarly put a lot of energy into training their staff, but they felt like they weren't always doing quality assurance around exactly how it was being presented. And so they had, instead of a kind of a formal training, they had a role-playing exercise that they did. And so what they did is they gathered up information based off of some notes of rejected vaccinations in the notes section of the EHR. They pulled maybe the 2 or 3 top responses, and most of those have been kind of sorted out through other organizations like the CDC. ACS has a lot of, if this is the question they ask or this is the pushback, here's a suggested response. And they just kind of role-played going back and forth. There's also an app from the AAP APA, and it's a simulation app where a provider is recommending, and they've put in the top 10 most pushback, which is effectiveness, safety, sex, all these items that I'm hearing. And so if people learn more individually, that's available too. As far as colloquially talking to your to your patients, so that was some maybe capacity building suggestions internally, to do the role playing and maybe be creative about different ways to educate. So the videos, like Teresa said, would be awesome, and maybe this app could be a complement. But when you're looking at your patients, I know this sounds pretty elementary, but the vaccine is older than the first iPhone, and it was given at this, it was FDA approved at the same time as meningococcal and Tdap, which are at 80 and 90%. It's also the most studied vaccine we have because of all the pushback we've gotten culturally around it. So I think, you know, the more people, we always try to do the less is more. I know you have enough data to probably make people's heads spin, but sometimes they'll say they're worried about the effectiveness, but it may be more emotional than that. And people who have like an emotional issue around it aren't always swayed by statistics. So trying to figure out if you can get to maybe asking why a few more times, because it may not be just the one article they read. I agree with the trust. I agree about probing further and making a personal connection. I want to see if I scribbled down anything else. As far as the statistics, we have great data coming from Australia and Denmark, folks that have done this way better than us and way earlier. It's really hard to say that cancer itself has gone down because the average age of a lot of the oropharyngeal cancer and cervical cancers are a little later, right, in the 30s and 40s and up. So the indicator that CDC has been using, and I was recently at a presentation where they were measuring effectiveness by infection. So if around cervical cancer specifically, infection or abnormal pap in those that were vaccinated versus unvaccinated. And that felt a lot more compelling to the providers that were sitting around in the room because it felt more tangible and that it was a preliminary outcome and not just cervical cancer itself. So I'm happy to share that type of data too. It could be a different way to look at it, that we're not looking at the end game that might be coming in 20 or 30 years in kids that are being vaccinated now. That was a data dump, but those were my preliminary thoughts.
No, that's great. I'm just going to say a quick couple as well, and then we'll turn it over to Lise to kind of give us a quick summary, and then we'll wrap up together. So I agree. I think finding out that exact specific concern, I find in working with practices is so important. And then, you know, again, I think it's, you know, relating that data to that. Again, if it's safety, you know, having a specific article on safety, a specific something on fertility. You know, I think there's some really nice pieces out there that like around sexual activity, the study that came out in 2018 of November 2018, cohorts and mandating the HPV vaccine in 2 states that do, and looking at that cohort, and it did not increase sexual activity. And that's a very recent study. So again, these things that we have, you know, maybe an access to. And so one thing I thought of too is, you know, would a study looking at the impact of waiting and showing how, you know, we know that those are vaccinated 11 and 12 years old, that their immune system, right, is stronger and better. So maybe providing that to them, just showing what waiting, you know, over time will do. So that's kind of a piece I was thinking of too. Again, we already kind of talked about some of the other things that I have here. And then I think also, you know, would it make sense to try to pull together like a parent resource sheet? So if you're identifying, you know, certain things that keep coming up, like length of time, like putting in some of the things like Anna just said about the length of time of meningococcal and DTaP and comparing that to the HPV vaccine, you know, that may be something that resonates. So just for length of time, that's all I'm going to say for now. I'll add other recommendations to the notes that are out to everyone, but I think those are kind of the first ones. The other one I want to just mention real quick is the oropharyngeal piece. When they were just talking and Angela spoke, we have some really nice pieces that are specific to oropharyngeal cancer, and that may be a different twist, right? Because we know oropharyngeal cancer has surpassed cervical cancer incidence, and I don't think parents necessarily know that. So that might be some great information to share too. So I'm going to turn this over to Lise to give us a quick high-level recommendation, and then we'll wrapping up.
Okay. Thank you, Jess.
Yeah, absolutely. Thank you.
First, I do want to say that I think some of the things that you're doing are great. You're doing a great job providing some of those resources that have already been mentioned. But some of the new things that were identified today is to describe the risk-benefits ratio in offering the vaccine in a more powerful way, and stressing the high value that the vaccine can have, taking a deeper dive in some of those talking points. A big one that we talked about was patients' level of trust with clinical staff and providers. It takes time to build trust, you know, and talking through the concerns that the parents have is important, and just really listening. A recommendation to share your personal experience of having your own child being given the vaccination can be powerful when you're talking with parents. Making sure that parents are aware of the oral cancers as part of the awareness of the HPV vaccination. It's really one of the only vaccines that can prevent some cancers. Another big one is addressing staff concerns and working with them to help them feel more comfortable in recommending the vaccination. There are some recent resources from the CDC using actual visual data on the side effects to share with parents. It takes a while, and that was stressed a number of times. Using videos from patient experiences to share with parents, like we saw today. There was some talk about the system in Texas, training staff on doing some role playing, which is a great recommendation. Gathering information from those rejected notes in the EHR, and addressing how to respond to a rejected note. Being creative. Let's see, well, there's a few more, but we'll add them to the additional notes. These are kind of redundant. Were those helpful, some of the new recommendations to the case presenters?
Teresa and your team, hopefully some of those might be helpful.
They are, thank you. We were just chatting about the role play and perhaps trying that during some of our connects and see how people are doing it. Just kind of today, tell me how you're presenting those vaccines and seeing how that goes. So that was a really good example. And we're looking at getting screens in our waiting rooms within our organization, so potentially being able to add some of those videos to that. So we do appreciate the feedback today. Thank you.